Thank you so much for the introduction, and good afternoon to everybody who's taken the time to join us for this afternoon session, which I hope will be informative and interesting and spark a little bit of debate amongst all of us here this afternoon. I've entitled this talk Dual Therapy Reemergence because, as we're going to see, if you don't look back at the past and what you've done, oftentimes you don't know where you're going to in terms of the future. And if, like me, you are an 80s child, this whole topic really reminded me of the Back to the Future movie, right? You've got to go back to your past to see what you need to change in your future. And so let's get going. Let's have a look. Okay, so let's kick it off with an audience survey. Let's see where we're all at in terms of the 60-odd people that are here today. So I understand the rationale and setting of 2 drug regimens in the setting of HIV management. So this is, as you know, completely anonymous. So let's kick it off and see where everybody's knowledge base is sitting at the moment. I hope nobody chooses number 3, but let's see.
All right, we'll give another 10 seconds.
Okay, so we have a nice split, actually, which is great. So we've got 40% of people who say somewhat agree, and 20% of you totally agree. So thank you for joining us in any case. And a couple of us, about a fifth of us, say not at all. So I hope today's session will be helpful for everybody, actually, who's joined. Okay, so in terms of the talk outline, as I mentioned before, we're going to talk a little bit about where we came from. We're going to talk about the history of 2 drug regimens, because without understanding the history, we may not understand why we're doing what we're doing currently. We also may not understand why we're moving forward in the way that we are. In terms of important 2 drug trials, we're specifically going to focus on a couple of them, because again, this helps inform and helps us understand why we're going where we're going. We're then going to talk about the really hot topic at the moment, which is the long-acting 2 drug trials and two drug regimens in the setting of HIV treatment. So are people doing this at the moment? Who's doing it? What kind of settings is it happening? And then again, we're going to be looking to the future of 2 drug regimens going forward again. So let's kick it off, where we came from. So as we know, I'm sure this is pretty much preaching to the choir of the people who've decided to take an hour out of their afternoon to sit and listen to me. ARVs really have transformed the world as we know it. People live longer. Perinatal infection is entirely preventable. Ongoing transmission, as we know now, is preventable with the U=U campaign. And in an ideal world, HIV is actually now totally preventable and manageable. We have options like PrEP, we have options like PEP, and we have options like safe and effective ART to make sure that this is indeed a condition which can be managed optimally. As we know, people live longer. I was an intern 13 years ago already, and really at the nadir of this graph, where people were coming in and we were just doing whatever we could to keep them alive at the time. And in the 13 years since, the average life expectancy of females has subsequently increased by 13 years, males by 10 years. And as we know now, there's basically no reason that anyone who needs ARVs, who is HIV positive, should not be on them. So let's unpack my statement a little bit and let's think about this. So ART has transformed the world as we know it. That's great, but nothing in life is perfect. People live longer, and we subsequently have an aging population on ART. A lot of research has been done into the pathophysiology of aging in retroviral disease, and so this is a field that a lot of people are looking into. But let's think about this specifically in terms of how we treat these patients who are living longer and getting older. What kind of things do we have to wonder about in these patients, and what things should we be focusing on? So ART tolerability becomes more and more important. As we know, our patients now live 10 to 13 years longer. So the best thing we can do for our patients is to make sure that those 10 or 13 years are indeed on regimens that are tolerable at the very least. The next thing to consider is drug-drug interactions. As we know, as we get older, so we pick up more and more comorbidities and we visit more and more health practitioners, and everyone feels like they need to prescribe something. So by the end of it, we leave with a shopping list of prescriptions. ARVs, although they were there first, tend to get muddled up in all of this, and so drug-drug interactions become very important. We now also understand that ART themselves impacts on age-related comorbidities. And so this is another factor that we now have to start thinking about. In terms of our aging population on ART, we have to push the conversation and we need to change the conversation. The conversation now is not the conversation of 13 years ago of how do I simply keep my patient alive. The conversation now in 2021 is how do I keep my patient alive and well and on their ART that doesn't give them too much trouble. This is a slide that's going to introduce you to the format of the talk. So if a slide is surrounded by a red border, this is a study that has been recently published, either out of the ID week or out of the IAS conference, basically something that's just happened, hot off the press stuff. So this is a really interesting study that was published in ID week, and it basically looked at the claims database of patients who were on Medicare. And it looked at patients specifically who were HIV positive, and it asked the question, what's happening to our patients? And it looked specifically at prescription refills of these patients. Bear in mind, this is not every patient on HIV treatment, and this is just a subset of patients, but a nice snapshot to see what's actually going on in the real world. So this was essentially a database of administrative claims of people who happen to be on this package of Medicare. And what they did is they followed these patients through over the course between 2014 and 2018. They wanted to see how many patients were on ARVs, what was happening to them in terms of demographics, what kind of ARVs were they on, and what kind of comorbid conditions were they picking up along the way. So as you can see, the numbers cumulatively actually increased to over 80,000 patients overall that were seen. And unsurprisingly, the average age of these patients increased from 48.9 years in 2014 to 52.4 years in 2018. And this was statistically significant. Specifically, if we look at the populations of patients who were 50 years or older, these populations increased from 50% all the way up to 62% of the overall population of patients. So there can be no doubt that these patients are living longer and reaching this age of more than 50. As we can see, somewhat reassuringly in the bottom graph, the proportions of people taking a non-nucleoside-based combination plunged all the way from 51% in 2014 to 29% in 2018. Similar pictures were also seen for patients who were taking protease inhibitors, where the proportions of patients decreased from 29.6, so about a third of patients, all the way down to 17.3% in 2018. And as you can see, there was a rapid uptake of the integrase inhibitor regimens, increasing from 27.1% in 2014 all the way up to 62.6% in 2018, with the biggest gain, in fact, being in 2018 of these patients. So our patients are getting older and we're treating them differently as they age. What kind of things do they pick up along the way? So this study looked at multimorbidity. To have multimorbidity, you had to have 2 non-HIV comorbid conditions. And so, as you can see, unsurprisingly, as we all know, multimorbidity rates also increased from 25.8% in 2014 to 37.2% from 2014 to 2018, where it was now 37.2%. And this was in an analysis of 83,000 odd patients. What kind of things did people pick up along the way? Well, the top 3, really, if you're going to think about it, is hypertension, hyperlipidemia, and neuropsychiatric conditions. I've included the other conditions alongside because I want you to start thinking about potential treatments that these patients would pick up along the way and potential prescriptions that would be prescribed to these patients for these kinds of comorbid conditions, and also then to think about potential drug-drug interactions with some of these drugs. When we look specifically at the rates of polypharmacy amongst these patients, the rates, unsurprisingly, increased as well. To be designated as polypharmacy, you had to receive more than 5 non-HIV co-medications. So as you can see, you really had to have a lot of people prescribing you a lot of things to meet this condition. Polypharmacy basically increased from 70% in 2014 all the way up to 76% in 2018. And prescription claims, in fact, mirrored these trends. The most used agents in terms of comorbid conditions were the cardiovascular medications, which increased significantly with a significant p-value between the 2 time periods. Other medications which increased significantly were antidepressant and anti-anxiety drugs. Chronic antibiotic use basically stayed the same throughout, The other classes of drugs that were used and statistically significantly more used, however, over this 4-year periods, included things like anti-diabetics. So I hope you guys are starting to think about what does she mean by anti-diabetics and how would this influence my patient who's on ARVs. So as an example, something like glucophage in patients on integrase inhibitors. The other significant increase was patients on steroids. Again, a drug with lots and lots of drug interactions with our ARV drugs. Something else to consider was proton pump inhibitors. And as we all know in clinical practice, these can very well be the undoing of our best laid intentions. Respiratory medications and osteoporosis medications also were on the increase. So there is no doubt that our patients are living longer, we're changing their ARVs as they go along, and they're picking up comorbid conditions and lots of polypharmacy out there. So now that we know where we've come from, let's talk a little bit about 2-drug regimens. 2-drug regimens, in fact, are not a new idea at all, and we're going to talk about how we've done in the past when we've tried some of these out in clinical practice. So there's really only one slide on how HIV medication works, and this is it. The name of the game for now is enzyme inhibition, whether you're inhibiting reverse transcriptase, protease, or integrase. This really forms the cornerstone of what we do. Those of us who've been in HIV care much longer than myself will remember the days where all that was available was zidovudine, a repurposed chemotherapeutic drug. As new drugs became developed, so out of desperation, in the late 1980s, we were using dual therapy treatment with zidovudine plus other NRTIs. Everything changed, however, in the mid-90s when we discovered PIs and NNRTIs, and so developed triple treatment, which is now the standard 3-drug regimen that everybody knows. In terms of drug development, not only have we included more classes of drugs, but the drugs that we are using have improved toxicity profiles over time. The dates next to these NRTIs are the dates at which they received European marketing authorization, and as we know, the drugs have just simply got better and better. So let's take a quick audience survey, maybe the first 3 to type in, we can read them out. So 3-drug regimens basically have been the gold standard since the mid-1990s. We've done really well with them, we've turned patients around, patients do well, and they remain preferred in consensus guidelines today. So why is today's talk on 2-drug regimens if the drugs are better tolerated, co-formulated, and standard practice, that is the 3-drug regimens? Why is this something that we are now starting to think about? Does anybody have any ideas? If you do, just type maybe in the chat box.
Okay, so we've got some votes for drug interactions.
Great, yeah, absolutely. I like that one. Any other ideas?
Evan, so it would be good to aim for a non-NRTI regimen.
Yeah, exactly. A nuke-sparing regimen. Yeah, there's a lot of interest around things like that. Absolutely.
Cost is another one that's coming up.
Yeah, someone from public health. Excellent, yeah.
Well, yeah, and for private people too. Toxicity
Yes.
is another one that's come up, and tolerability.
Yeah.
And
okay, yeah.
Drug interactions with comorbid conditions too, as well.
Yeah, excellent. So you guys are all on the right track as to why we're even having this talk today. Let's go through those one by one. So we know our patients are getting older, and whenever you think about why we would want to do these changes, think about this little old man and about all his problems that he's collected over his life. So as we mentioned, first of all, absolutely, concerns around long-term toxicities would be an issue. We know that these are cumulative. Our patients are living longer, we're giving them drugs for longer, and so the chance of them having these toxicities increases over time. We know about abacavir and cardiovascular disease. We know there's nothing that reaches significance, but there is a signal, and we know pathophysiologically that the endothelium is altered in the setting of abacavir, and so this has made it into guideline recommendations. We now know, especially about tenofovir and renal disease, we know that the cumulative tenofovir exposure is associated with increased risk of chronic kidney disease. We know about tenofovir in bones as an example. So again, thinking about this little old man standing in the corner of your screen and what we're exposing him to cumulatively. Other things to think about, and I'm so glad you all brought this up, would be to reduce pill burden, potentially to improve adherence, reduce drug-drug interactions, very importantly. It's cheaper, absolutely, like you guys actually mentioned. And then to save classes for later if the patient fails, again, thinking about the future and where we might head to with our patient. So in terms of learning from the past, how have we done when we've done this? Well, the truth is the early studies were essentially abysmal. And if you do any kind of research and you get a forest plot that looks like this, you may want to consider your life choices. So this was in fact a Cochrane review that looked at patients who were virologically suppressed. So they were actually doing fine, and they were then switched to a 2-drug regimen. Well, how did these patients do? They did really badly, and all studies actually favored the control. As you can see, some of these studies are old. The forest plot on the bottom, as an example, looks at some of the very old PIs that were done, like indinavir, as an example. So very old. So we tried, we didn't do well at all. So why might this have been? Well, we might have had the right idea, but potentially the drugs that we were using at the time were not ready for our ideas. So then we entered, as I mentioned in the previous slide, the era of high boosted PIs. And so this idea of 2-drug regimens didn't really go away when this happened. And so I've highlighted the dates of all of these studies so that you can see what happened as we transitioned and as we tried newer and newer PIs as they came out. The first study in 2008 really looked at efavirenz plus Eluvia. I personally can't imagine a worse combination of ARVs for a patient to take versus Eluvia plus 2 NRTIs at that point standard of care. So those patients who were on dual therapy failed more, they had more hyperlipidemia, and they had more NNRTI resistance. So certainly not at all a place where we want our patients to be at. The next study in 2014, the NEAT 001 study, looked at tenofovir FTC plus darunavir. So you can see that the PIs are starting to evolve here. Looked at that plus darunavir versus darunavir plus integrase inhibitor raltegravir. So we really are trying to give our patients the best chance here on a dual regimen. It did meet non-inferiority, but the patients didn't do well if the viral load was high and the CD4 count was low. And so I want you to remember this study because this is going to be important when we talk about future studies and further studies that have been done in this realm. The next study in 2017 was the SALT trial, again with a different PI. Here we're dealing with atazanavir, ritonavir plus 3TC versus atazanavir and 2 NRTIs in virologically stable patients on ART, and was found to be non-inferior. So potentially as the PIs are getting better and more potent, we're starting to see that a 2-drug regimen is not impossible. The last study that I've included here is one from 2017, the dual Gazeta study, which looked at darunavir plus 3TC versus a 3-drug regimen containing darunavir and 2 NRTIs, again in virologically stable suppressed patients, and again showed non-inferiority to a 3-drug regimen. So the question started arising, well, it probably matters what kind of PI you're using in terms of your 2-drug regimen. But as we all know, and as we kind of have alluded to in previous slides, using a PI regimen isn't ideal because of intrinsic problems with the PIs. We know, again, of multiple drug-drug interactions. And if any of you are prescribing PIs, I'm sure you have the Liverpool app on your phone because these are drugs that you're constantly checking for drug-drug interactions in. We know about the higher rates of adverse events like GIT side effects, and we know about metabolic problems. So this is not a strategy that we would use out of choice in a patient who we want to be stable and living 13 happy longer years with their ARV in. As we know, drug development has progressed. We've got ARV options. We now have options. The options are more potent. They have higher genetic barriers to resistance. And so we really have a smorgasbord of options to choose from. As some of us have alluded to previously, cost is something that we have to think about as well. This is a really great study out of the Lancet. I think it's about 3 years old already. And this is a great study because it speaks to the South African situation. And it really looked at our previous standard of care, which was tenofovir, lamivudine, and efavirenz, and compared the strategy of that versus tenofovir, lamivudine, and dolutegravir in different subsets of patients. And so this is a really great study because it actually looked at disability-adjusted life years and a version of these. And so we started asking questions about what happens to our patients down the line. And so unequivocally showed that our current first-line regimen containing dolutegravir really was the way to go in our setting. So we had some drugs that were working, sort of. We had PIs that were better, sort of, but maybe not in the long term. Maybe what we needed all along was something with a little bit more power to get us there. And so this really has happened with dolutegravir in terms of the 2-drug regimen setting. As we know, the first generation integrase inhibitors like raltegravir and elvitegravir often have cross-resistance and have a lower genetic barrier to resistance. However, dolutegravir was developed as a second generation integrase inhibitor with improved resistance profile and high efficacy rates. Unlike raltegravir, dolutegravir has a half-life and is actually efficacious in the presence of other integrase resistance mutations like the Q148 pathway. And so this seems to be the kind of drug that we really want to think about in terms of two drug regimens and what we're doing going forward. So let's talk about two drug regimen trials, and I'm specifically going to focus here on two drug regimen trials that use dolutegravir in them. They're going to be broken up into three groups and three ways to think about them. And the way that I group these mentally in my own mind is dolutegravir plus what? And we're going to start with the grouping that certainly has the most data behind it. And this, in fact, is dolutegravir plus 3TC FTC. I'm going to speak very quickly about the first two trials, the 2017 PADL and the 2018 ACTG trial, because these were really the trials that laid the groundwork for the subsequent ones, which are the Gemini and the Tango trial, which certainly have informed a lot of what we do. So let's start right at the beginning. Let's see where we came from and understand where we're going to. So the PADL study was really a proof of concept study. As you can see, the number was really small. We only had 20 patients who were treatment naive at this point. Genetic baseline resistance was excluded, and they all had viral loads of under 100,000 copies per mil, and obviously were negative for hepatitis B. You can understand that you can't give a patient monotherapy for their hep B. And the proportion really was out at 48 weeks. They wanted to see how many of these 20 patients managed to suppress after 28 weeks. Despite the inclusion criteria wanting really just patients with a viral load of less than 100,000, somehow 4 with a viral load of more than 100,000 snuck in onto the study, and the baseline CD4 count in these patients was 507. How did these patients do? Well, they did okay. As you can see, this is the proportion of patients who are virologically suppressed, the figure at the top, from baseline all the way out to week 48. There were patients that had blips along the way, but these patients generally resuppressed on continuation of therapy. So all patients were suppressed at week 8, upwards onto week 24, and 18 out of 20 reached that primary endpoint of a viral load of less than 50 copies per mil. The median change in CD4 count was 267 cells, and so this is a study that really started paving the way around the conversation of dolutegravir in a two-drug regimen. At this point, it was still novel, so this novel regimen warrants further clinical research. So this is where it all started. The next year, the ACTG group, 2018, started enrolling a few more patients because now we had this proof of concept that had been done. So this is a trial that looked at 120 individuals, again, with no major baseline resistance. They started pushing the envelope here a little bit, and so the viral load that was allowed was a little bit higher, perhaps emboldened by the grand total of 4 patients from the previous PADL trial. Exclusion criteria were those with active hepatitis B and major resistance mutations. What did these patients look like? Well, the median age was 30 years. A third of them were Black patients, with 13% of them being female patients. I want you just to remember these numbers. So the proportion of Black patients and the proportion of female patients in these studies as we go forward and look through the other studies. The median viral load was a log of 4 with a CD4 count of 387. How did these patients do? Well, they did well as well, even when stratified as to the viral load being less than 100,000 or more than 100,000. If your viral load was more than 100,000, you took slightly longer to virally suppress, but you did get there in the end and you did maintain it. Again, a 90% suppression rate. However, there was a little bit of a warning in the study, and the warning was around virological failure. So 3 individuals in this trial had virological failure, and they all had at least one very low dolutegravir plasma concentration, likely due, they thought, to suboptimal dosing. However, worryingly, one actually developed dual-class resistance and another a single integrase inhibitor mutation. So although the conclusion was generally positive, there was a warning in this conclusion that a participant developed dual resistance mutations, and so something to think about going forward. The next 2 trials I'm going to study that we're going to talk about really form the cornerstone of a lot of what we do. So I'm going to spend a little bit more time on these ones. The first trial to talk about is the 2019 Gemini trial. This is 2 parallel studies that looked at between 710 and 720 patients per arm. So as you can see, the numbers exponentially are larger in these studies. And so this is why I'm going to spend time on these trials. And the endpoint really was the proportion of patients with HIV viral load that was undetectable at week 48. This is a START trial, so these patients were not on any ARVs to start with. You had to be an adult patient, again, with an HIV viral load up to 500,000, as it was in the ACTG trial from before. Again, hepatitis B was an exclusionary criteria, and you had to have no major HIV resistance mutations. Randomization was really balanced along the HIV viral load. So we were really starting to get interested in how was the viral load responding, because we'd had that data from ACTG that perhaps it wasn't exactly the same. And importantly, CD4 counts being either above or below 200. Each arm recruited over 700 patients, so certainly a huge study that was undertaken. Let's have a look at what these patients looked like. So these were patients who were on average 30 years old. The female proportion, again, didn't even reach kind of 1 in 5. In terms of the HIV RNA, we specifically are interested in those with an RNA of more than 100,000, because this is really where we're interested. And as you can see, these patients formed a proportion of about 20% of the total cohort. Similarly, with CD4 counts, we were interested in those patients who had CD4 counts below 200. And as you can see, these patients were severely underrepresented in this trial, not even making up 10% of the overall population. How did these patients do? Well, on the face of it, they did just fine. Non-inferiority was met. And this was whether it was intention to treat or per protocol analysis that was done. And so non-inferiority margin was met in this study. Let's break down some of the research here, and let's look at things specifically that interest us here. So specifically, we are interested here in that CD4 count of below 200, bearing in mind, of course, that these numbers are very small, actually. So here I've highlighted it for you in terms of what happened to these patients. And as you can see, if the CD4 count was very low, these patients certainly didn't respond in the way that we would have wanted them to. This result does demand a little bit of further interrogation in terms of understanding what exactly happened with these patients. Remembering, as I said before, this is on a background of very few patients. So this is looking at an undetectable viral load in these patients at week 96. And I specifically want to single out this little block here at the end. So here's your patients with CD4 counts of under 200 and what happened to them. As you can see, the patients on the DTG 3TC arm did significantly worse in terms of virological suppression. If you interrogate this data a little bit further, there were in fact 20 patients who were on the DTG 3TC arm who made up this proportion of non-responders. If you look in terms of what these 20 patients actually constituted, 2 patients had HIV viral loads of more than 50, and 3 had confirmed virological withdrawal. So 5 out of the 20 patients had confirmed virological failure. The other 15 of these patients withdrew for reasons like treatment-related adverse events, non-treatment-related adverse events, protocol violations, loss to follow-up, withdrawal of consent, withdrew to start HCV treatment, and 1 was incarcerated. So as you can see, if you actually look at those patients who failed in terms of the per protocol analysis, it really was 5 out of the 20. If you look as well on the 3-drug regimen arm, so the dolutegravir, TDF, and FTC, that 87.3%, there were 7 patients who did not suppress, and of those 7, 1 had confirmed virological withdrawal, and the other 6 were excluded for other reasons. So 3 were lost to follow-up, as an example, 2 withdrew consent, and 1 was incarcerated again. So potentially not as clear as these graphs would have you believe off the bat, but certainly something to think about. So what happened to the viral load as we went forward? Well, patients suppressed, and you couldn't have done this better if you took, I suppose, tracing paper. And the lines were essentially exactly the same between the two in terms of rates of virological suppression over time. The median adjusted increase in CD4 was comparable between the 2 arms as well. And again, time to viral suppression, again, you couldn't have planned this better if you did a study really traced over each other. And this held true even if your patient's baseline HIV viral load was more than 100,000 in that analysis. So let's talk a little bit about some nitty-gritty about this study. So in terms of primary outcomes at week 48, it was non-inferior. The cutoff rate in this trial was used at 10%, and we're going to talk about why these cutoff rates are important at the end of this talk. So here we have a cutoff rate of 10% to prove non-inferiority. Viral suppression rates between the two groups were comparable and met this non-inferiority rate, and there was no emergent resistance in either arms. In terms of secondary outcomes, tolerability and toxicity profiles mostly were similar. However, if you were on dolutegravir and 3TC, your renal and bone biomarkers significantly favored the switch. There are a couple of concerns, however, about this trial. So the DTG 3TC underperformance or relative underperformance, especially in patients with baseline CD4s of under 200. But as I said in the beginning, these were severely underrepresented, less than 10% of the total population. But we were worried anyway because of the NEAT 001 trial. So this is not news, and it wasn't anything that was completely unexpected. And so the evidence for reproducibility in patients with low CD4 counts may have been limited by this bias. At week 96, there was maintained statistical non-inferiority, but only just if we use this 10% non-inferiority margin. And at week 144, there has been one case of resistance to dolutegravir that has emerged. So again, the story about resistance in the background that we have to be thinking about. Let's switch gears now and talk about the TANGO trial. So remember, the Gemini trial was patients who were not on any ARVs who were initiated on a 2-drug regimen. The TANGO trial from the same year, 2019, is a switch study. So this is the study that looked at patients who were stable on first-line ART. They had to have been on TAF, FTC. If they were on tenofovir, they were switched to TAF before they were allowed in, plus a PI, which was boosted, an NNRTI, or an integrase inhibitor. These patients generally had to have been virologically suppressed for about a year or more than a year and had to have a viral load that was undetectable at screening, and again, hepatitis B, surface antigen negative. The randomization here was open label and was really randomized by the third agent of the ARV, the background ARV regimen that patient was on, to ensure balance in terms of outcomes at the end. So about half the number of patients from Gemini. Here, there's 370 patients on in each arm. One group switched straight away. The other group continued their ARV, switched at week 144, and outcomes at week 196. So how did these patients do, and what did these patients look like? Well, I'm sure some of you can maybe guess at how these patients might have looked. So the median age here is a little bit older. We're sitting around 40 years old. The percentage of females don't even reach really 10% in this cohort of patients. These are patients who were well experienced on ARVs with a median time on ARTs of 33 months. So going on 3 years really of ARVs, and CD4 counts very high, above 600. In terms of the randomization, as you can see, these groups were well balanced, but there was some bias towards patients who were on integrase inhibitors or alvategravir colbistat, that these patients certainly made up larger proportions in those patients who were on a background regimen of NNRTIs or PIs. Again, something to consider, that we had less than 20% of patients in this trial were Black. Again, women severely underrepresented. And again, patients with CD4 counts of under 350 in this trial made up 9% of the switch arm and 8% of the TAF arm. And around 2/3, as I mentioned, were taking a background regimen of alvategravir and TAF at study entry. So balanced, but a little bit heavy on that arm. In terms of primary outcome, it was those patients with a detectable viral load, essentially. As you can see, the non-inferiority margins between the primary and secondary outcome, which was patients who were virologically suppressed, was different. Primary outcome was a confidence interval with a difference of 4%, and secondary was 8%. How did these patients do? You guys are going to get a little bit sick of seeing graphs that look like this, but we'll power on through. So they did comparably well, and non-inferiority was in fact met. However, there were some virological failures along the way. And of the DTG3TC group, there were 4 patients, and on TAF-based ART, there were 3 patients. However, all of these patients actually resuppressed down the line, and the median CD4 count between these patients was equal. So we're starting to get this idea that there may be blips in the background of these patients, but they generally resuppress. In terms of the TANGO trial, it looked a little bit further in terms of other outcomes, not just a viral load response. So it looked specifically at things like weight, at renal markers, biomarkers, inflammatory markers, things like that. So in terms of the adverse event of increased weight between the two groups, the continuation of current TAF FTC tended to have a little bit higher rates of increased weight. In terms of the lipogram and the findings on the lipogram, a DTG-3TC regimen certainly had a positive outcome on these parameters. So again, something to think about in our patients who are aging. So how did it do? Primary outcomes, both arms did just fine with very few virological failures and no resistance emergence, although we did have those blips along the way, 3 in 4 cases. Adverse events were similar in the two groups, but drug-related events actually were more common on the 2-drug regimen, which is not surprising because you've taken patients who haven't been on dolutegravir before and putting them on dolutegravir now. So what kind of drug-related events are we talking about? Well, these were predominantly neuropsychiatric, as you can see. So anxiety, insomnia, and then the weight issue with fatigue as well. So something just to bear in mind in this group of patients. So this is an update of the 2019 Tango trial that was presented at the 2021 ID Week. And what have they done subsequently? So they're now starting to look at virological outcomes and further data on weight, metabolic, renal, and inflammatory biomarkers from baseline all the way out to week 144 in these patients. So what did they find? So changes in weight actually at week 144 was similar between the groups. However, those patients who were obese at baseline and received a TAF-based ART versus the 2-drug regimen, the dolutegravir 3TC, were more often referred for weight management. In terms of fasting lipids, again, it continued to favor the dolutegravir 3TC arm. In terms of renal biomarkers, the renal biomarker difference was really small out to week 144, which was quite interesting, with the majority of the change really being an EGFR from creatinine. But when you look at the renal function in terms of cystatin and urine PCR, it really was comparable between the two groups. So overall comparable, but when you look at the EGFR from creatinine, perhaps not. So at week 144, again, maintained its non-inferiority, and there was no confirmed virologic withdrawal or resistance. No new safety signals, reassuringly, happened between week 96 and week 144, and the adverse events were comparable between the groups after week 48. Again, similar changes were noted in the outcomes, the metabolic outcomes that they were looking for, but really the fasting lipids favored the DTG-3TC arm of this trial. Let's move on to the next group, and the next two groups are going to go quite quickly because there've been a couple of trials, but nothing as big as Gemini or Tango. So the next combination that was looked at was dolutegravir plus rilpivirine, the second generation NNRTI. And so this was evaluated in the 2019 SWORD trial. The SWORD trial was a switch study. So these were patients, again, who were on ARVs, who were stable on their ARVs and had been for at least a year. Again, hepatitis B, surface antigen negative. 500 patients in each of these arms who were randomized to receive either dolutegravir plus rilpivirine to continue their current treatment. Those who continued their current treatment were switched at week 48 onto dolutegravir plus rilpivirine, and outcomes were assessed at week 148, with an undetectable viral load being the primary endpoint. Oopsie. Okay, so how did these patients look? Again, average age of 43, female. Here we're cresting 1 in 5, so we've got 23% female patients, non-white, 20% of our patients. CD4 count, again, very high in these patients, treatment experienced and doing really nicely. CD4 counts of well above 600. In terms of the baseline ART that these patients were on, the majority of patients had TDF in the baseline, and then in an RTI-based treatment in terms of randomization according to the third drug. How did these patients do? Well, they did comparably, and so non-inferiority again was met for this trial in both SWORD-1 and SWORD-2, which ran concurrently. In terms of other endpoints to think about, in terms of metabolic profiles, there was no change between bone atherogenesis and inflammation markers. However, if the patient was on dolutegravir plus, if they were on the 2-drug regimen, the renal tubular proteinuria was actually improved and maintained. Interestingly, this was one of the studies that started looking at patient satisfaction. What do our patients want? I suppose is the important question always to ask. And so patient treatment satisfaction actually improved on patients who were on 2-drug regimen, dolutegravir, rilpivirine. In terms of final outcomes, so again, it demonstrated high efficacy and was non-inferior, in fact. In terms of virological failures, there's a couple of things to talk about here. So in terms of virological failure, 1% of patients, so 10 patients overall, had virological failure, which was a viral load of more than 200 on 2 occasions. However, reassuringly, there was no emergence of resistance mutations to the integrase inhibitor, but the NNRTI, as we know, has a lower genetic barrier to resistance, and so 3 of these patients developed resistance to the NNRTI. This is one of the patients who managed to fail, but resuppressed subsequently. And reassuringly. So this was one case at week 48. She had a very high viral load, which she started at more than 2 million, received TDF, FTC, and efavirenz to start, and was then switched to the 2-drug regimen, and had documented non-adherence before week 36. And as you can see, her viral load subsequently obliged and went all the way up to 1 million, and she subsequently resuppressed. She did develop a genotypic resistance mutation, however, phenotypically remains sensitive to rilpivirine. Something to think about in this trial certainly is the discontinuation rates between the two. So on the face of it, discontinuation rates of 5.7 and 6.7% between the 2 arms, whether they continued or switched, seem to be mostly comparable. But really the devil is in the detail with this. When you look at the adverse events, so the adverse events, 17 of those 29 when the dolutegravir plus rilpivirine arm versus only 3 in the 34 of the continuation of ART. And again, for similar reasons in terms of neuropsychiatric reasons. If we look at those patients who discontinued, who were on continuation of ART, 14 of the 34, so essentially half of them, were due to consent withdrawal. So again, very different reasons for discontinuing, and something to bear in mind. So these are exactly what I was just talking about, the adverse events that led to the dolutegravir rilpivirine discontinuation. So 49 of the 990 patients, so 5% at week 100, including 17 for psychiatric disorders, so about half for the psychiatric problems that we know we may encounter in the setting of dolutegravir use. Okay, one more to talk about. So this is dolutegravir plus darunavir ritonavir. So this is essentially a nuke-sparing regimen, as we alluded to earlier. So this is a study out of 2019 called the Dualis study. So it took patients who were on ARVs and basically switched them or continued them on their background regimen. Both arms actually contained darunavir. So patients again had to be virologically suppressed and then were switched. The primary endpoint was an undetectable viral load. So how did these patients do? So in terms of each of the arms, there's 130 odd patients per arm. On the 130 on the 2-drug regimen, 3-drug regimen, 132. And again, just to look at why the patients fell out of the study. So in terms of the reasons for premature termination within the study, on the 2-drug regimen arm, 4.6% was due to adverse events. And on the 3-drug regimen arm, if you add up other reason or withdrawal of consent, you really are sitting at the vast majority of patients. So different reasons for patients falling out. How did these patients do overall? Well, no surprise, most of them were male, most of them were Caucasian, most of them suppressed, and discontinuation rates, as I said, were higher on the 2-drug regimen. Reassuringly, again, no treatment resistance emerged on this regimen. So we're going to switch gears now, and we're going to talk about the long-acting 2-drug regimen trials, because this is really where a lot of the focus at the moment certainly is sitting in terms of the conferences that happened this year and the research activities that are going on. So there's really only, there's a couple of regimens to talk about, but there's really only one big one to talk about in this afternoon's session. And this is cabotegravir long-acting plus rilpivirine long-acting, and the 2 trials that have looked at this. There are a couple of others. There's the Latte trial as well, which is the first one that happened. But I've specifically included these 2 because they are the most up-to-date, and there is some news and some movement from recent congresses on them. The 2021 Flair study is a study that looked at patients who were ARV naive. So here we have a START trial. These patients were obviously adults, they had detectable HIV RNA, and interestingly enough, there was no upper border on the viral load for this study, as there had been previously of 100,000 or 500,000, depending on which study you looked at. They wanted patients with any CD4, and again, hepatitis B surface antigen negative, and baseline resistance testing was done on these patients with no NNRTI RAMs. However, K103N was actually allowed into the study. So this is a study that is a little bit complex in terms of how it worked, but once you understand how it works, the rest will be smooth sailing. So from Before day 1, which is randomization, for 20 weeks before, patients went on induction ART. The induction ART was an oral regimen of dolutegravir, abacavir, and 3-TC. They were then randomized either to maintain their current regimen or to switch to an oral cabotegravir plus rilpivirine combination. The reason for the oral lead-in phase is really that if you have any side effects, at least you can manage them when it's an oral regimen, much easier than when you are in fact injecting long-acting antiretrovirals. Those patients who were stable on this oral lead-in phase were then transitioned to the long-acting every 4 weeks. As you can see, 278 out of the 283 that started the oral cabotegravir were able to transition. There was an extension to this trial at week 96, and so this extension is some of the data that's come out this year, which we'll get into a little bit later. Importantly, if the patient had an HLA-B5701 mutation, they were allowed to be on an NRTI that was not abacavir. Primary outcome, again, was a detectable viral load. Secondary outcome, again, as a viral load that was undetectable, and then looking at resistance emergence. Participant preference, I thought this was quite interesting because if you're going to sell something, a new drug delivery system, I suppose participant preference is just about everything. And week 96, efficacy and safety. How did these patients do? Well, week -20, so this is at baseline enrollment, that oral abacavir containing regimen. Average age of 34, females, again, really not making up much of the cohort at all. Black or African American making up 20% of the cohort. In terms of those patients with HIV viral loads of more than 100,000, remember there was no cap on this trial. They constituted 20% of these patients, and those patients again with low CD4 count. So these are the ones we really want to concentrate on, really not making up much of the cohort at all, at again under 10% of the cohort. So I'm sure you all could have guessed exactly what this is going to show you. So it really met criteria for non-inferiority in terms of primary and secondary outcomes. And so this, even when adjusted for gender and baseline HIV RNA, whether the viral load was below or above 100,000. So again, just speaking to the durability of dolutegravir, the new agent, of cabotegravir plus rilpivirine in terms of the potency of these drugs that we are using. There were, however, confirmed virologic failures. Within the 3-drug regimen arm, there were 3 cases of virological failure with no emergence of resistance. However, I just want to draw your attention to the long-acting regimen arm, where there were 4 cases, and in fact, 3 of these 4 cases had both NNRTI and integrase inhibitor resistance-associated mutations. There is a little bit of work going into this in terms of background ART regimens, and if the patients had been exposed to NRTIs as well as HIV genotype, looking at whether these influence some of this. And there is some data, some very early data talking to this and how this may be the fact. However, in the Flair study, plasma cabotegravir and rilpivirine arms, the concentrations at the time of failure were actually below the population means, so potentially giving a reason for why these 4 patients failed and 3 developed resistance mutations. In terms of participant preference at week 48, I think this is quite interesting. So 91% of patients actually preferred the long-acting ART, with 1% preferring to continue on their daily oral therapy, and I guess 8% remained undecided. Interestingly, and again, a little bit of a warning to us, is that 1 patient actually fled hepatitis B on this trial. They had been vaccinated, but the vaccine wasn't working yet. So again, a little bit of a warning about Hep B and what we do. So this is recent data that's come out in the Lancet on 14th of October. So this is really the extension arm. And this is looking at week 124 endpoints and what's happened to all of these patients. And the little bit of the twist in terms of what's happened with the latest data in this trial is that they've kind of amended how they're switching patients. And this is quite interesting. So at week 100, those patients who were on the oral group still, they could either elect to switch to long-acting therapy, or they could carry on with what they were on, or they could withdraw. And those who decided to switch to long-acting therapy could either go direct to injection, or again with that 4-week oral lead-in dose. So again, similar to what was done earlier in the trial, you could have tablets for 4 weeks and then switch to the injection arm. And so this is one of the first trials that looked at straight to an IM regimen. So 232 patients transitioned at this point at week 100, with 111 of them being in the direct to injection group and 21 in the oral lead-in group, that 4-week oral lead-in. And 99% of those who went direct to injection actually remained suppressed. And there were similar rates in terms of virological viral loads that were suppressed between the two groups, as well as adverse events leading to withdrawal. In terms of those patients who'd started all the way back, 243 out of the 227, sorry, of the 283 participants actually remained suppressed. And this is all the way out to week 100, week 144. We had a 5% rate of viral loads that were detectable, including 5 additional participants since the week 96 analysis. And there was a 5% adverse event rate leading to withdrawal of the trial. And so really, this kind of regimen and this kind of idea is gaining more and more traction in terms of data as it goes out. And whether or not you use an oral lead-in phase or whether you go straight to injection seem to have similar outcomes. Week 124 showed that it remains a durable maintenance option for patients as well. So certainly quite exciting. The next trial to talk about is the Atlas study. So this is a similar study. If you look at kind of how the drugs were assigned and what happened with the oral cabotegravir arm, the difference, however, between the previous study, the Flair study, and the Atlas study is the Atlas study was a switch trial. So these were patients who were on ARVs already. Again, did really well in terms of their previous ARV regimens, were suppressed for 12 months and suppressed at enrollment. These patients, again, were either continued or switched with that same oral cabotegravir rilpivirine lead-in phase, and again extended at week 52 to 4-weekly cabotegravir rilpivirine arm. Primary objective were those patients who had a detectable viral load. How did these patients look? I'm sure you guys are getting sick of this, and this is the last one I will show you. I'm sure you all by now have seen what I'm trying to do. So female patients were 34%. Black or African American patients, 20%, good CD4 counts of 653, and really treatment experienced, really well-behaved patients who'd been on ART for 4 years and had done really, really well on their ARTs. How did these patients do? This is almost the last one I'm going to show you that looks like this. And even if you adjusted for things like gender and baseline third-class agent, non-inferiority was still met. As you can see, these non-inferiority margins between all these trials are a little bit different. Here we're dealing with 10 and 6 and 10 and 10. So we'll come back to that again just to remind you. Non-inferiority, however, was achieved for primary and secondary endpoints. Again, because we have to think about this in our patients, confirmed virological failures. Within the dolutegravir, abacavir, and 3TC arm, there were 4 cases, again, with no emergence of resistance, and they're all resuppressed. In the cabotegravir long-acting plus rilpivirine long-acting, there were 3 cases. And again, similar to the previous trial, the concentrations at the time of failure were below the population means in all 3 of these patients. In terms of patient-reported outcomes, I think this is quite an interesting thing. So again, because it's a long-acting, it's an injectable, if you don't have buy-in from your patients, you may not ever get buy-in. So this reported how patients felt about this, how satisfied they were with the change. And as you can see from baseline, those patients who found things like injection site reaction, ISR, and pain definitely increased as time went on. So in terms of the totally acceptable group, this went from a rate of 50% for injection site reactions all the way up to 67% as the trial went on. At the end of week 48, those who preferred the long-acting were 86%. 2% still preferred to stick to their daily oral therapy. And I suppose, again, rest in the middle were undecided. Okay, so what's new in terms of the Atlas trial? Well, the data from the Atlas 2M study has just been released again out of Lancet HIV. This came out on October 11. And this is really looking at, do we have to give our patients injections every 4 weeks? What happens if we try and give our patients this long-acting ART regimen every 8 weeks? Does it make any difference? And so this enrolled patients who were already on the Atlas trial, all patients who were on standard of care ART, and patients who outside of the trial, and patients who are on standard within the Atlas trial. And so they landed up with numbers of 522 and 523 per arm. So again, nice big numbers. And they were randomized to receive rilpivirine cabotegravir every 4 weeks or every 8 weeks. And the outcome was to see how many of them had a viral load that was detectable at the end of week 48. So as I said, 500 patients per arm, median age of 42, and 73% of these patients were white, with 27% of them being assigned female at birth. So how do these patients do? I've really just highlighted the numbers I want to draw your attention to in terms of primary and secondary outcome. Primary outcome of an undetectable viral load was comparable between the two, and secondary outcome of a detectable viral load more than 50, comparable between the two. So really reassuring. If we break this down in terms of those patients who had detectable viral loads within the 8 and the 4-week group, comparable rates that met non-inferiority threshold of 4%. If we look at those in the secondary outcome with undetectable viral loads, again, the 8 and the 4-week group were comparable and met non-inferiority. So this is really quite exciting that instead of our patients having to come back every 4 weeks to receive ARVs, this can potentially be drawn out to every 8 weeks. In terms of confirmed virological failures between the two groups, there was one additional participant actually within the 8-week group. Remember, this 8-week group was contained patients who previously been on the 4-week regimen. The cohort did contain some of those. So there was one additional participant within this 8-week group. Reassuringly though, no new safety signals were identified and adverse reactions were comparable between the two groups. And generally grade 1 or grade 2 in terms of the adverse reaction. This is a really nice study because now we're starting to get more and more kind of data coming out in terms of long-acting regimens. So this is a trial, well, a retrospective review actually that was presented at ID Week, and this looked specifically at patients who were on injectable regimens, specifically from Canada and the US. It combined patients who were from Flair, Atlas 2M, who were on these long-acting injectables. And what they wanted to do is they wanted to see if their patients in the US and Canada were any different to patients from elsewhere in the world in terms of these outcomes that we're all looking at. So in terms of the snapshot, whether the patients were on 4-weekly injection, they did just the same as patients from all over the world, or whether they in fact were on 8-weekly injections, they did the same as trials from elsewhere in the world. And in fact, more than 92% of these patients actually maintain virological suppression on this injectable regimen, which is similar to the overall pooled rates. Something that was quite interesting that came out of this was people are trying to guess at who's not going to do well on long-acting injectable ARVs. And so there've been prior studies that looked at baseline factors for failure, baseline risk factors. And really these were identified as being rilpivirine RAMs, HIV-1 subtype, again, like I alluded to, this A6A1, and a BMI of more than 30. They previously in other studies have shown that this modestly increased the risk for confirmed virological failure. And so in this retrospective review, they wanted to see if this in fact held true for their patients. In this analysis, 3 out of all of those patients had confirmed virological failure, and 2 of whom had more than 2 baseline factors in terms of why they failed. But reassuringly again, all 3 actually resuppressed on alternate regimens during long-term follow-up. And in fact, in terms of their analysis, although bear in mind n equals 3 does not a summer make, no patients with a high BMI were actually found to have failed. There is a concern, however, that rilpivirine RAMs tend to be quite predictive in terms of who's not going to do well, and so this is something that's going to have to be looked at.
Michelle, sorry, we have run out of time. Can we give you a couple more minutes to finish?
Sure.
Cool.
So 2 drug regimens in the setting of HIV treatment. So let's quickly go through this. Quick audience participation. Do you know of any treatment guidelines that recommend 2 drug regimens in them? Okay, so split, and E, I'm not sure. Okay, I'm so glad you guys are here. So, so the answer is 2. There are actually two international consensus guidelines that recommend 2 drug regimens, and we're going to just talk about them very quickly. So between Gemini and Tango, it really did open the door in terms of justification of dolutegravir plus 3 TC's inclusion. The two guidelines that recommend come from the DHSS, which is the US Department of Health and Human Services panel on ARV guidelines for adults and adolescents, and the EACS, which is the European AIDS Clinical Society. And I just want to draw your attention to the fact that although they are in these guidelines, there are certain provisos that you have to think about with these patients, and certain patients who do not qualify, in fact, for 2-drug regimens as initiation. If you are working in Europe, your patient obviously can't have hepatitis B, can't have a viral load of more than 500,000 copies per mil. And this may in fact be an offshoot to the fact that the trials that have been done on this certainly haven't evaluated patients with very high viral loads, and they should have CD4 counts of more than 200. And so this may be, again, be borne by the fact that our trials just don't look at these patients very often. In terms of the DHSS guidelines, the difference here is really that you need baseline resistance genotypic testing. You can't use it again if the HIV viral load is more than 500,000 in Hep B co-infection, but there's no CD4 count cutoff for these patients actually. So this is the difference between the two trials. Some practical issues to think about. So the regimens studied often do not contain tenofovir and TAF, which is probably okay unless you have hepatitis B where you work in. And as we know in South Africa, estimates range anywhere between 1 and 10%, average of 6.7% of our population, in fact, have hepatitis B co-infection, with 2 studies of NRTI regimens that contain tenofovir not doing well at all, failing to achieve non-inferiority. And as we know, TAF remains essentially virtually unstudied. We know the drama around dolutegravir and rifampicin containing anti-TB regimens. If you've only got 2 drugs in your regimen and you're going to knock one out because you don't adjust for concurrent TB, you may well be in trouble. We know about weight issues. We don't do baseline resistance pattern testing in our patients, and certainly in the Tango trial, only 1% of patients had the M184V mutation, so difficult to infer how they're going to do. Pregnancy, we know it's not a reason to not prescribe dolutegravir, but there may still be some reluctance from the healthcare provider and the patient, and around same-day start, some unresolved issues. Okay. Okay. Have we got 2 more minutes?
1 more minute.
1 more minute. Okay. So this is a stat study. This was presented at it was published in AIDS and presented at the IAS. So this was same-day start of patients who presented to US clinics. And basically treatment was modified in 8 patients, an overall of 9% of patients. So this was same-day start. Baseline resistance testing was done. Hepatitis B was done at initiation. They were started on 2-drug regimens, and basically 8 of these patients had to be switched, predominantly for things like hepatitis B down the line. Okay, I'm going to leave, on this one. So these are some trials that are coming up, which are quite important and are starting to ask important questions. Not only how do 2-drug regimens do, but where can we fit them in terms of our program. So this is a trial that's looking at 2-drug resistance, 2-drug regimens in patients who are failing first-line ART. So this is patients who have a history of not doing very well on ARVs, and it's looking at dolutegravir plus darunavir ritonavir in second line versus dolutegravir plus 2 NRTIs in second line. Importantly, this is a study that's starting to look at low and middle income countries, including South Africa, and study completion date is estimated at 2023. So in conclusion, 2-drug regimens are not a new idea. Previous issues have been around available options that we've had. We know that dolutegravir has really changed the paradigm. We know that the long-acting injectable agents are certainly going to change the conversation. But the knowledge gap still extends to the real world outside of clinical trials in terms of older people, in terms of the patients that we see with very high viral loads, very low CD4 counts. And that's it. Yeah, I'm done. Thank you so much. So I think we are moving really to a point now where science fiction is really starting to become science fact, where we have new drugs available to us, and watch this space. It's going to be very interesting. That's it.
Well, thank you so much. Just going to go through one question really quickly. So it says, Dr. Spencer's asking, what about the adherence data? What's it like in the long-acting injectables? For example, in other words, will this ever be an answer to non-adherence?
You mean the patients who are on long-acting injectables, how will they do if they're non-adherent?
On the long-acting injectables, how adherent were they?
So the drug levels were lower than population mean, but they actually had made their appointment dates. So again, maybe some PK/PD stuff that needs to be elucidated in these patients. They were not patients who didn't make a difference. They were there every 4 weeks, but the levels were subtherapeutic.
Okay, well, great. Thank you so much for showing us an overview of all the data for the 2 drug regimens. It's definitely something to consider. It's always a little bit, it always sounds exciting when we've always got the problem of Hep B in this country, but the problem of viral loads and CD4s, which does apply. And then, of course, the real world applicability, always with people who are a bit less adherent than in trials. The other one concern, I suppose, is that a lot of our treatment initiations for those 2 drug initiation regimens are not true initiations. I think the majority now of initiations are actually reinitiations. In other words, people have fallen off the wagon somewhere and just not told their provider. And so they often end up with resistance mutations as well on initiation. It's a big challenge, but it's certainly something for the future. And it's really nice to have these options for some of these cases where it does apply, even if it's a fairly restricted